Dear moderator, just you start your talk just after 10 seconds.
আমরা শুরু করবো আমরা?
স্যার আমি বলছি স্যার একটু আর কয়েক সেকেন্ডে লাইভে যাব।
শুরু করেন।
Yes sir, you may start. We are live now.
Good evening, everybody, and Assalamu alaikum. This is the 53rd class of this session, I should say, of our ECG study group. And today, we are going to have case-based discussion from Dr. Nur Alam. He's at present working as Assistant Professor of Cardiology in our National Institute of Cardiovascular Diseases. Dr. Nur, I'm fortunate enough to be his teacher. He obtained his MD Cardiology degree from Dhaka Medical College. And from that perspective, I know him very well. He's very energetic, enthusiastic, and if you put his mind to achieve something, he really does it. And also in academic ground, he tried to be a teacher. And that's what he's doing. He's doing very nice, very well as a teacher. Today, we'll be seeing his progress as a teacher of cardiology. And this session will bear proof to that fact. Ladies and gentlemen, let us go and enjoy together the case-based discussions that will be put forward by Dr. Nur Alam. Alam, the field is yours.
Thank you, sir, for your kind words. Actually, I always feel proud to be a student, to be a direct student of you. And thanks again, sir. I am now sharing my screen. Is it visible now?
Yes, we can see it.
My voice is clear, sir.
Yes, yes, nice.
So thank you again, sir. Actually, I feel very much privileged that I am presenting a case-based ECG in front of such a learned gathering. Especially, I would like to mention Rafique, sir. He is a very student-friendly teacher. So far, I saw him. As I see him, I become amazed how he become very simple, being a very learned, but he behave like very simple. I always am amazed at seeing him. Thank you, sir, for giving me the opportunity. I'm Dr. Nur Alam, as Abdul sir said that I'm going to present case-based ECG. I will show 4 ECG cases. Every case is having 3 or on an average 3 or 4 slides. So let us start. Mr. A, 70 years old, hypertensive and diabetic male. He has a history of PTCA with extending to LCX in 2015, and now he presented with severe chest pain. So now look at his presenting ECG. If we see here, there is a white complex tachycardia as we looking, and heart rate is 111 beats per minute, and it seems to be regular. If we look the bottom of the ECG, the rhythm strip, we can look here that this encircled QRS complexes having a bit narrower in oid in relation to, in comparison to preceding and successive QRS complex, and also there are POFs present, and so with this, if we look at the if we look at the differential diagnosis of void complex tachycardia, there are most of the void complex tachycardia are according to the study results. Most of the almost 80 to 85% void complex tachycardia belong to ventricular tachycardia, and 15 to 25% belong to SVT with aberrant conduction, and a small percentage on to 5% belong to pre-excited SVT and SVT with ventricular hypertrophy and dilatation and cardiomyopathy and congenital heart disease, and also some drugs like amiodarone and electrolyte imbalance. So if we look at the Brugada algorithm, here we can see that in the present ECG, according to the algorithm, the R2S interval more than 100 milliseconds in on precordial leads, and also there is AV dissociation, as I mentioned, POV is there, and the AV dissociation in VT, there is a sensitivity is 82% and specificity 98%. And if we look the morphological criteria of VT, we can see that there is not all morphological criteria fulfilled in the present ECG, but there is a wideness of the R wave in V on that is more than 0.4 second. So this fit. So not all criteria for morphological criteria fulfill the present ECG. So according to this criteria, and as well as the patient presented with acute ischemic problem, acute ischemic syndrome, so we consider that it is a ventricular tachycardia. After the treatment, the patient reverted to the sinus rhythm. His heart rate becomes 75 beats per minute. It's regular, and there is a incomplete right bundle branch block, and there is a old MI inferior and lateral ischemia. With the treatment, successive ECG shows same, and there is a prolonged PR interval. That's first degree AV block. We may consider that it may be drug effect due to beta blocker. So with this is my first case. Sir, should I proceed or stop here for discussion?
Dr. Nur, can I ask you something? Let's go to the first ECG.
Sir.
First ECG. First ECG. This one. In V2, there is a sharp upstroke, a small R. Does it goes in favor of SVT, or does it go supraventricular complex, or does it go for ventricular complex? Rafique sir, will you make some comment?
Well, this is a very interesting ECG, and I'm glad that Wadud pointed it out. I mean, if you look at the circle part with the blue circle, there is a P wave and there is flooding. It looks like pre-excitation, but it is not. I'm glad that you presented this case. This is a fantastic ECG. It is a VT, and the sinus rate is so close that those P waves, if you look at those P waves, one may confuse it with pre-excitation, but it was a slow VT. So I would like to have a copy of this ECG. This is a very good ECG.
So,
great.
Of course,
the problem will be that because the morphology is changing, you will not be able to use the morphology criteria as much. But if you look at lead V1 and V2, the initial R wave is wide, more than 40 milliseconds. And that fits into the description of VT. But this is, when I looked at it, I said, oh, it looks like W, but it's not. This is amazing. Fantastic ECG. Thank you. Let's go to the next one.
Yeah. Nur, what medicine did you use? Amiodarone?
No, sir. Interestingly, with the conventional anti-ischemic drug like heparin and antiplatelet, the VT reverted to the sinus rhythm, sir, not
That
ambient.
means the patient did not have any hemodynamic instability.
Yes, sir. He was stable, sir. He was stable.
I mean, the rate is about 100. So it's
And that's the
close
reason.
to accelerated idioventricular rhythm that you see with acute MI or during reperfusion.
And
So
that's why I was saying, sir.
yeah,
It seems like it could be actually slow VT, idioventricular rhythm.
exactly. Exactly. Great ECG.
Very nice ECG. Very good presentation. Next ECG, please.
Yes, sir. So my second ECG is 60 years old lady. She is hypertensive. She has diabetic nephropathy. She has end-stage renal disease and on maintenance hemodialysis. And she complains of breathlessness during her dialysis period. So let us look her ECG. As we see here, the rate is 170 beats per minute. Rhythm is irregular, and there is a absent POF. Rhythm is irregular, and there is a absent POF except for the last beat in the bottom of the ECG. That seems to be a sinus beat, and there is a variation of the R wave heights, and QRS duration is 68 milliseconds. There is narrow. So, so with these findings, we may comment that this is a atrial fibrillation with first ventricular rate, but there is on and beginning of the sinus beat also, and that might be considered as a paroxysmal atrial fibrillation. And the alteration of the R wave height that is mentioned may be patient having pericardial effusion. With this regard, I would like to show the third case. Then we'll discuss. Hopefully, this is related. And the 70 years old lady having chronic rheumatic heart disease with severe mitral stenosis, having left atrial thrombus, and she has a history of stroke with left-sided hemiparesis. She had hypertension, diabetes, and presented with palpitation and breathlessness. So let us look for the ECG. I beg apology that I could not make the full ECG visible. Just I took the mobile snapshot in OPD from OPD. So what are we seeing here? The rhythm is regular. QRS is narrow, rated 100 beats per minute. If we look at this four complex of QRS complex, a narrow QRS complex having a different morphology of POF than the preceding sinus POF. So we can consider it as an atrial runs. So if we consider the atrial tachyarrhythmia, there are four types of atrial tachyarrhythmia: atrial fibrillation, focal atrial tachycardia, and multifocal tachycardia, and as well as atrial flutter. If we look the origin of the impulse in atrial fibrillation, there is a erratic atrial depolarization, and in atrial tachycardia, that's why there is a fibrillary OF. In there is no POF, there is a fibrillary OF, and RR intervallar irregular. And focal atrial tachycardia, there is a POF having same morphology in each rhythm, each beat. And the atrial rhythms are regular as it's come from a single focus. And multifocal atrial tachycardia, there is a different morphology preceded by QRS complex and RR intervallar irregular. And in atrial flutter, there is a sawtooth-like appearance, and that is and the origin is a macro entry of the circuit. So this is my second and third case. First one is this one. Sir, please unmute, sir.
Both are CKD patients.
No, sir. This one is a CKD patient. Then later on, the atrial runs on a patient as a severe mitral stenosis patient.
Sir, I have a question to Rafique, sir. Sir, we have problems with these CKD patients. what drugs can we use? We use beta blocker or calcium channel diltiazem or verapamil, mainly diltiazem, to control the rate. But sometimes the patient goes into hypotension, and then we have to use a digoxin or amiodarone. Which one will you prefer?
Well, CKD patients are a problem because you cannot use sotalol.
Yes, sir.
You can use sotalol, but you have to dose it very infrequently depending on the creatinine. So amiodarone is what we end up with, even though I hate to use amiodarone in younger people. And the other problem is the blood pressure problem, because they can be hypertensive and during dialysis, they become hypotensive. Well, this is our problem. I mean, Bangladesh not mean dialysis patient. So amiodarone is the one that we left with, even in younger patients. Thank you.
And I would like to make a comment on that. Sometimes we do use, like, as for example, like definitely beta blocker or diltiazem, depending on the blood pressure. But in CKD patient, one dose of digoxin for initial rate control probably could be given, 0.5 milligram. And then we can control the rate. Most commonly, they will come down. But definitely daily dosing is problematic. But if necessary, digoxin dose, digoxin dose, you can do every 48 hours or something like that and monitor that. That's also possible. But definitely amiodarone would be the drug of choice here, unless there is no other contraindication.
And absolutely, digoxin, even though kidney is a problem, but
Yes.
giving 1 or 2 doses in acute situation helps in these cases, and it doesn't create toxicity because you're not using long term.
Yeah, that's the problem we face. Actually, we had a patient in ICU. She had paroxysmal AF for a long time, and they have to use amiodarone for quite a while. And sometimes I have used digoxin infrequently, as you have said, just to control the rate, 1 or 2 doses.
Yeah.
But again, it relapses again and again. That's a very problematic thing. What can we do in these patients? Because they are very stable, but whenever they have atrial fibrillation with fast ventricular, they become very unstable and end up in ICU again and again.
I mean, that's why amiodarone long term becomes a good drug, because amiodarone has no problem with the in renal failure patients. This is one situation that I make exception even in young people.
Nur, can you show the second ECG?
This is
Yeah,
a
this one.
mitral stenosis patient, sir. Severe
Mitral
mitral stenosis, having LA thrombus, and she presented with palpitation and breathlessness. Her ECG is like that. So my focus in these 4 successive beats that are different P morphology. So it is actual runs, and it could be a multifocal atrial tachycardia also, sir. What do you think, sir?
Look at the last 4 beats in V6. The last 4 beats, 2 have similar morphology of P-wave, and the 2 others are a little bit different. Sir, could it be a multifocal atrial tachycardia?
Yes, it's possible, because I mean, you cannot clearly see the morphology, but if you make an assumption, so it's multifocal atrial tachycardia or atrial tachycardia. I mean, one thing that we have to make sure that this is not atrial fibrillation. That's very important, because you can see the P waves clearly, because if it is atrial fibrillation, like not in mitral stenosis, other cases, you have to anticoagulate patients depending on their age, but this is not atrial fibrillation.
So Rafique, sir, another question I have here, because it's very short run. I think in order to call it multifocal atrial tachycardia, normally they last a little bit longer, probably, the duration wise. Is that right?
Well, normally I call it atrial tach. For me to define atrial tachycardia, I have to see more than 2 morphology of P wave clearly. So if I put this case in an exam and ask a student, is it multifocal atrial tachycardia? That will be an unfair question to ask. But it is possibility. Yes, it may be multifocal atrial tachycardia. Thank you.
One of my observation is that in atrial fibrillation patient, sometimes we may see the POFs. POF seems to be like sinus POF, but that is a clear-cut atrial fibrillation ECG. So could it be, sir, in atrial fibrillation when the impulse coming around the pulmonary veins, a gentle and handsome POF can be produced, sir?
Oh, the question is, can I have sinus P wave while atrial fibrillation is going on?
Sir. Exactly.
Almost impossible. You can have flutter and fibrillation together. We have proven that. We used to put catheter in the coronary sinus and leave it there, and we find that the right atrium is in fibrillation, left atrium is in flutter. In those cases, you end up seeing these organized waves sometimes, which looks like P wave. So I think it's more like that rather than sinus P wave.
That's a possibility, yeah.
So may I proceed, sir?
Fourth case, please. Interesting ECG. Very simple, but very interesting.
Thank you, sir. And my fourth case and the last case, actually, Mr. X, 60 years old, male, hypertensive, diabetic, admitted with the complaints of chest pain for 4 hours. As I working in a cardiology unit, not in a EP unit, so my cases are most likely patient presented with chest pain and ischemic patient. So patient presented with chest pain for 4 hours. On examination, pulse is 60 beats per minute. Blood pressure is 120 over 70 millimeter mercury, and heart sound is audible and normal. Lungs are clear. So when we see the ECG of this patient having chest pain, the rate is 60 beats per minute. Rhythm is regular and pair interval normal, and there is a T inversion in on AVL and V6. So one could appreciate that this is a ischemia, lateral ischemia. So let us see in successive ECG. The ECG is showed that there is a rhythm is regular, rate 65 beats per minute, and there is a biphasic deep T inversion in V2, V3, and V4, and also there is a T inversion on AVL and V5, V6. So in next ECG also showing the same features. There is a biphasic deep T inversion in V2, V3, and there is also deep T inversion in V4, V5, V6. So with this finding, biphasic TOF with the deep T inversion, we can diagnose it is a case of Olens syndrome. And in the investigation, most of reveals normal, except there is a troponin I is raised. So we can diagnose is a non-ST-SCS. So what is a few lines about Olens syndrome? First described in the early 1980s by Olens, Dizoan and colleagues. They identified a subset of patients with unstable angina who had a specific precordial TOF changes and subsequently developed a large anterior MI. Also, this Olens syndrome referred to as LED coronary TOF syndrome, and that represents a pre-infarction stage of coronary artery disease. So Olens syndrome is a clinical syndrome characterized by biphasic or deeply inverted TOF in V2, V3, plus a history of recent chest pain now resolved. It is highly specific for critical stenosis of the left anterior descending artery. In first picture, we are seeing the type A pattern, that is biphasic TOF, and in type B pattern, only deep T inversion in the anterior precordial disc V2, V3. TOF changes can evolve over time from type A to type B pattern. That over time, the biphasic TOF may turn into only deep T inversion, and that is turning from pattern A to pattern B. So the clinical significance of this biphasic TOF or Olens syndrome is patients may be pain-free by the time the ECG is taken and have a normal or minimally elevated cardiac enzymes. However, they are at extremely high risk of extensive anterior MI within the subsequent days to weeks. Due to the critical LAD stenosis, these patients usually require invasive therapy and do poorly with medical management and may suffer MI or cardiac arrest if inappropriately stress tested. So in Nolan syndrome, we have to think, or we have to predict that there may be proximal LAD occlusion, and so treatment should be accordingly. So this is all about my presentation.
So what, did you do a cath on this patient?
Yes, sir. We did cath of this patient, and I missed the cath. I used the fluoro or CD. A patient having proximal LAD occlusion, and we stented it.
Okay, can you go back to the first ECG, please?
Yeah, that's the very important thing.
No, not this one, the one before. Before.
Yeah.
This is the first ECG, right?
Yes, sir.
Okay. So this is an interesting ECG because when somebody comes with chest pain, and that's it, I don't care what the ECG is. Chest pain is chest pain. But that chest pain cannot be explained by one AVL. Look at V2, V3, V4. It doesn't look right. In V2, we can see some ST elevation, but not in V3 and V4. Actually, this patient had some, and as if the concavity is trying to disappear. So that struck me when I looked at this ECG. And that fits in with the subsequent EKG. So that's why it's important. I think between this ECG and the second ECG, what is the time difference?
This first ECG and second ECG, that is almost 8 hours, sir. 8 hours.
Okay, so that's the whole point, that we have lost so much time. And
Rafique bhai.
Yeah.
Abdul bhai, welcome.
এই প্রথম ইসিজি দেখে যদি আপনি এটা দিয়ে মানে বলা মুশকিল যে there is a significant coronary issue going on. It is very.
Patient was having chest pain, Hafiz.
No. First কথা রফিক ভাই, আমি সবসময় এগ্রি করি যে if the EKG is a tool, the patient is, if the pretest probability of the clinical assessment is that I cannot explain anything, 10 out of 10 chest pain, diaphoretic, I don't really care about the EKG.
That's my point. That is my point,
yes,
Hafiz.
Yes, agree. And then if you're looking for some objective evidence to go along with your clinical assessment, then EKG is a very good tool, and then troponin is a very good tool. Problem is, EKG may not be helpful, and troponin takes time. So if there is overwhelming situation, that patient is having this kind of problem, then it is better to think about that way. Problem for us, Rafique bhai, for interventional cardiology.
I was so happy that you were not here.
But I have one
whole point that Hafiz and I'm trying to make. If you showed me this ECG in an asymptomatic, I will totally ignore it.
Exactly.
But somebody who is having chest pain, and as Hafiz said, I'm trying to find something supportive.
Right. Exactly. It is very difficult for us in interventional cardiology to go in with just symptom. We need some objectivity to go in. At second point, আমাদের স্বার্থে যদি এই ECG দেখায়, আপনি যদি আমাকে স্যাটারডেতে বলেন আপনি আরেক হাসপাতালে, আমি আরেক হাসপাতালে, হাফিজ আইসা এটা এনজিওগ্রাম করে দাও, রফিক ভাই এই ইকেজি দিয়ে এতে এনাফ না, আর একটু ওয়েট করি দেখি ট্রোপোনিনটা বাড়ে কিনা, বুঝছেন, তা নাহলে তো আমার লাইফ হেল্প।
Yes, but this is a good ECG because I'll tell you why. Between these 8 hours, I need to know whether the patient was pain-free or not. And when I say pain-free, I never ask the question, do you have any chest pain? I ask, are you back to normal? Do you have any kind of funny feeling in the chest? If the answer says, no, there is no funny feeling, I'm back to normal, I'm happy. But until that time, I'm not going to leave this patient. And Hafiz, do you agree with that?
So that's
100%.
why it's important when the patient have chest pain, and I do suspect there's something going on, we should be repeating the ECG.
That is right. That's the
After
point.
15 minutes, 10 or 15 minutes later on.
Yes.
And
Yes.
that's the most important thing. That's has been also stressed in the guidelines.
এবং ওয়াদুদ আমি এই যে বোর্ড রিভিউর কোশ্চেন দেখি তো ওরা জিজ্ঞাসা করে what is the next step in the management? One, repeat EKG, wait for troponin, do echo. The answer is repeat EKG to see any dynamic EKG change. And it is in the Braunwald's classification of unstable angina, right? That and then indication for going to the cath is that ongoing chest pain, dynamic EKG change, non-sustained VT, refractory VT, heart failure, hemodynamic changes. All these you go straight to the cath.
And I totally agree with that, because the reason is one important point we are missing here. We did not hear what's the dynamic of his chest discomfort, because the second ECG is after 8 hours. I have a good feeling if we would have an EKG in 15-30 minutes, we have seen more ST elevation. I have a good feeling on that, if the patient is symptomatic.
But Aziz bhai, that is true. But when you see the next EKG, it is all declared. You know, because we never.
Alam, can you show the second ECG?
Yes, sir. I'm just telling what happened to this patient. The patient presented with chest pain and having this ECG with raised troponin, and he got enoxaparin and antiplatelet drugs and just a non-STSCS management, conservative management. And just after getting this medication, within half an hour, patient is symptom free. But as the patient is symptom free, so the second disease is taken a bit later. So when the patient is symptom free, then this ECG appeared.
But I want the audience to look at the second ECG, and please remember, this is a wellness feature that we should be paying attention to. They should be more aggressively treated, these patients. And please never ever send these patients to stress test. You will induce a heart attack in this patient, even cardiac arrest.
Yep. Thank you. Good ECGs.
Good ECG. Very simple, but very practical. Alam, thank you.
Yes, sir. Just I want to show the last slide. That picture I took from Chowdhury Ahmed sir's on presentation. He showed this picture. I took from there. Good judgment comes from experience, and experience, well, that comes from poor judgment. Thank you, Ahmed sir, for your nice collection. I took it from your on lecture in FSCAI last month, couple of months ago. Thank you, sir.
We really enjoyed it. Anyone from our panelists, do you want to make a comment?
Actually, I can put the first ECG again, because one thing that I like to make sure for our viewers that definitely we should not miss AV dissociation there. We didn't comment on that much. Okay, because it's very clearly
very first one.
very first one. Yeah, there's some AV dissociation going on, and that's one of the criteria for VT. We have to look at it.
Thank you.
And please look at the bottom, because you will see that the P waves are marching on their own, and they are disappearing within the QRS complex, again reappearing at the end of the line. So the middle complexes, even though they look like pre-excitation, they are not. The ventricular complexes and the atrial complexes are marching on their own rhythm. This is nice.
It's interesting. It looks like there is a VT, but there is a sinus tachycardia underlying.
Yes.
Yes. Hafiz bhai, you are very right. And that's what Rafique Ahmed was saying. Both the sinus tachycardia and the ventricular rate, both are almost same. And that's why this confusion arises. It was a very good ECG.
Thanks.
And Rafique sir, Are you going to
Yeah.
present some cases?
Yes. So can you unshare, please?
Yes, sir. Okay, sir. Thank you.
Alam, many thanks.
Thank you.
Today, Atahar Bhai is, he could not get away from the cath lab. He was very much engaged with a difficult case.
Give me 1 second. When I got this ECG ready, I was happy that Hafiz is not here because I have to use my imagination. Now I have problem. But I have answers for him. Let me see. Share screen.
রফিক
So-
ভাই আমি আমার ফেলোদেরকে বলি যে for interventional cardiology you need brainstem, for EP you need cerebral cortex.
So this is something that I showed last week, but I'm going to follow on that. So this is my first ECG. That this is the old one, but I just want to make sure that we are remembering things that we did. This is the one, and I have this. Revo, if you could give us about 20-30 seconds, and then if you look at most of my ECGs, you will see the heart rate written in the corner. So don't worry about the heart rate.
Review poll dibe?
Yes. Hold please.
Review poll, please.
Rafique bhai, this EKG is straight from the SEC, board, cardiology board.
Mhm.
It's exactly same question, বুঝছেন? আপনার option গুলো একটু different, but 1 and 4 were there.
Yeah.
And I'm going to learn this from you now.
Is the poll on?
Would you please elaborate on short RP and long RP?
Yes, we're going to
Let's
go
Yes,
over.
start the poll, sir.
Yes.
Okay.
So today actually it's going to be short RP, long RP issue. I'm going to have series of ECGs on this.
Mhm. Nobody is saying that's nice. Sir,
I hope everybody,
doing well.
I hope everybody answers today, or at least majority answers. Please do answer. Please remember your answer so that when we discuss, so that you can, as the Nur Alam said, experience comes from poor judgment, and that's very, very true. And actually, this is Hafiz is saying so. If we don't make poor judgment, nothing will happen to us. Great.
রফিক ভাই 1 আর 4 হলে আমি আসি।
Okay. Sure. All right. So the choices, majority said atrioventricular reentrant tachycardia, sinus tachycardia, 12% atrial tachycardia, and 5%. So let's look at it. I'm going to go to the next slide. So this is what it looks like. I have expanded it, and what I can see in lead 3, I can see a P wave. And if it is the P wave, I have measured it. Beginning of the R to the beginning of the P wave, 220 millisecond, and P to R, 120 millisecond. So this is what we call long RP tachycardia. So let's look at it. So these are the way to diagnose. If in a SVT, P wave is not visible, truly not visible, it is most likely AV node reentry because it is buried in the QRS complex. And then if the P is visible, we measure R to P and P to R. If RP is shorter than PR, then it is either AV node reentry or atrioventricular reentry. If it is close by, if it is a little out, but still RP, then it is more likely to be AV node reentry. If RP is longer than PR, which in this case, it is either atrial tachycardia, sinus tachycardia, or it can be atypical AV nodal reentry tachycardia if the P wave is inverted. So, majority answered atrioventricular reentry tachycardia. That is a possibility, but unlikely possibility. So it could have been number one, atypical AV node reentry or atrial tachycardia. And I'll go for both. I'll give a correct. So the way to distinguish it will be, if I give adenosine, and if the tachycardia stops, then we are stuck. We cannot have it. But in this case, we gave adenosine and the tachycardia continued. And I can see without QRS complex, there is tachycardia. It was clearly atrial tachycardia, because it is unlikely that we have developed AV block and the AV node reentry will continue. Number one. If it is atrioventricular reentry, you cannot have atrioventricular reentry without participation of the ventricle. So that's out. So this was a case of atrial tachycardia. But it was an interesting case because the P wave is negative, so atypical AV node reentry was also a good choice.
Rafique bhai, the atypical AV inerty,
Yes.
fast, slow.
Yes. Will be almost same. Will be same ECG.
কিন্তু যদি atypical AV inerty আমার মনে হয় একটু explain করেন.
Okay, I'm coming. We'll come to that. So this is the ECG during sinus rhythms. And if you can see that in lead 2, P wave is upright in sinus and inverted in lead 3. So that made it difficult, because if it were positive, it would have supported more either sinus tachycardia or atrial, but being negative, so we have to take both atypical AV node reentry and also atrial tachycardia. I'll come to that, Hafiz, your question. We have some pictures. Now I have this one. This ECG, actually, I made a mistake. For many, many years, I put it in the wrong folder. And today, as I was looking at it, I changed my mind.
Rafique bhai, EP guys, they always change their mind.
It's the sign of cerebration.
Yes.
This looks like a sinus tachycardia.
Yeah, so let's give the poll. Let's give poll.
Okay.
Ripu, poll daw.
Yes, sir, start করেছি.
Okay.
Variety.
Majority, so it's a good distribution. Good number of people. Majority says sinus tachycardia.
কিন্তু তার ওই যে lead 2
So
তে স্যার
I-
ঝামেলা লাগাচ্ছে।
Yes, I have some comment on that, because
please.
let's see, just once, let me move the polls thing. Let's say lead 5 also very clear, lead 2, because I see at the end of the QRS, there another
Yes.
notch there,
Yes.
another notch at the end of the QRS, lead 5 very clear, and that marches that. Those P wave, like atrial activity, that marches that. I could not exclude atrial flutter also.
Okay.
Or
Hafiz,
the rate of, let me see, but rate is 123, so.
123. So the rate was 123. And if you look at lead 2, 3 AVF, P is upright, 1 is upright, AVR is negative, almost looks like sinus tach.
Yes.
But what struck me is if you look at lead 2, the end of the QRS complex is funny.
Yes.
But if you look at lead V6, you can
It's
clearly
clear.
see another notch.
Yes.
That is correct. Yeah.
Now, so it was based on this. This is actually more so. I have another ECG on the same patient the day before, same heart rate, 125. And you know, I always tell that if the heart rate stays constant for a big period of time, 125, 123 is not a big difference. It's almost same heart rate for 2 days. So that means this was atrial flutter. And this is the patient during sinus rhythm. Clearly see that in lead 2, you don't see the end slurring. So if I go back, please remember this lead 2 where I'm pointing, you can see my arrow, right?
Yeah.
Then if you look at this one, you see the lead 2 end, as Aziz was pointed, that is another P wave. So this was atrial flutter with 2-to-1 conduction. But I think 125 rate is such a difficult rate, slow, 123. Yeah. So remember this, that I always look at ECG. This is the borderline rate. If for 2 consecutive days, the heart rate is 110, 120, 100, then it is not sinus.
আপনাকে আমি রিকোয়েস্ট করব যদি atrial flutter atrial tach দুটোকেই correct ধরা যায় কিনা?
Yeah, it's a question of semantics because 123, if you double it, it becomes 246. 246 is a little too fast for automatic atrial tachycardia, that the one that we typically use. So, but if you tell me that, I mean, I'll have to accept it, but by the book, it goes into the diagnosis category of atrial flutter. But you're absolutely right, can be, okay. So,
sir, that means whenever we have a atrial flutter or atrial tachycardia, one of the most important distinguishing point is the rate.
Yes, rate, because let's say rate of 150. Mechanistically, there are 2 kinds of flutter at tachycardia. One is automatic atrial tachycardia. That's the one that we normally talk about. But it can also be a macro reentrant atrial tachycardia or micro reentrant atrial tachycardia. That can become faster, macro reentrant atrial tachycardia, faster than normal flutter. So it gets blurred at certain point. It is only way you can do it is that if you find a long period, a pause without QRS, and you cannot see any baseline, then it is more likely flutter than tachycardia. But you cannot see it in this case.
And interestingly, this same EKG and the previous EKG looks similar. Looks like.
Yes. Okay, now this one. And I'm using the term here, typical AV node, and in the other one, I put atypical AV node, and we'll talk about it, what it means in the next few slides.
It seems that people are listening to you.
You know, I mean, there's a smart group of doctors here.
Heart rate মনে হচ্ছে 148, 46.
What is that? I can't see it in the bottom.
130.
130.
130.
It's a slow tachycardia.
ওই যে এমআরসিপির এক্সামিনেশনের সময় যদি এক্সামিনাররা হেপাটোস্প্লেনোমেগালি এক না হয় তাহলে ওরা ওই কেসটাকে রাখে না। এখানে ফ্যাকাল্টি একমত যদি না হয়।
Okay, so we have all diagnoses here, except
I loved it.
Okay. So do you want me to talk or anybody else wants to talk?
রবি ভাই, আপনি আমাকে একটু অন্য কথা বলেন তো। মনে করেন যে এই রোগী আমি ইয়ারে আছে, আমার ডিফারেন্সিয়াল ডায়াগনোসিস আছে, এখন এটাকে ট্যাকল করার জন্য কি করতে হবে?
Oh, so I mean, it depends on the symptom. I mean, I'll come to that. Before I should not bias. We already have answered. So the question would be, this is a tachycardia. It's a narrow.
স্যার একটা কমেন্ট করব স্যার?
Yeah, please.
এখানে যে আনসারটা নাই, ওর কিন্তু এটা একদম রেগুলার না, একটু কিন্তু ভেরিয়েশন আছে। If somebody says it's atrial fibrillation, will he be wrong?
Well, atrial fibrillation, you have to have an extreme degree of irregularity.
Yeah, but he doesn't have that. But look at the lead two, the first
yes,
two
there
piece
is some
and
irregularity.
the third piece, there's a difference.
You also have to understand that if you have AV node re-entry or anything that involves the AV node, we'll have some oscillation in heart rate because AV node can be influenced by the autonomic tone. So let's look at this. What is the possibility of this one? So this is same patient during sinus rhythm lead 2. I have pointed out, look at the end of it. And over here, there is something.
Yes.
So it must be a P wave. It is the same day ECG. So this is a P wave. Okay, if this is the P wave, I'm going to go into this business of long and short Rp tachycardia. So I measured it from the R to P was 80 millisecond and P to R is 380 millisecond. So this is a short Rp tachycardia. And the short Rp tachycardia, I'm going to go long Rp tachycardia are sinus tachycardia, atrial tachycardia, atypical AV node re-entry, which is less than 10% of AV node re-entry tachycardia. Then short Rp tachycardia, AV node re-entry tachycardia, atrioventricular re-entry. If it is AV node re-entry, P wave more likely to be within 70 milliseconds of the care, which is in this case it's close there, 80-70 milliseconds. So, and if P wave is not visible AV node, there is a P wave, it is 80 millisecond, and my primary diagnosis is AV node re-entry. Now, here it comes. So what happens? Typical AV node re-entry, we go down through the slow pathway. So the electricity, this is the AV node. Electricity is coming through the slow pathway, taking a long time, and then going back through the fast pathway, and same time going down to the heat. So it goes quickly up and quickly down and producing this P wave and the QRS complex. That's typical AV node re-entry. Let's reverse it. If I go down through the fast pathway and then come back through the slow pathway, the P wave will come late. And that will give long Rp tachycardia. So, and a typical AV node re-entry is about 10% of total AV node. So, have you any question on this?
একটা কথা আমি বলতে চাচ্ছি যে মানে আমরা যেরকম নন স্পেসিফিক এসটিটি চেঞ্জেস প্রোপোনিন আসলে একটু অন্যরকম চিন্তা করি। আপনার এই রোগীর যে মনে করেন ইয়ারে আছে অ্যাডেনোসিন দেওয়ার পরে ডায়াগনোসিস করলে কেমন?
Oh yeah, oh, no question, no. SVT, you have to, it comes to my question, your question, yes. There is an SVT, I cannot see, even if it is other, like you give adenosine and you give the diagnosis, and then after that, if the patient is stable, you can basically send the patient home, depending on the frequency of symptoms. Yeah, clearly. But for us, as you said that it's the question of making our brains think. Just like the wireless ECG. Why do we need that? We can just do an angiogram. But this is something that we exercise our brain. An academic person.
Whenever we have this type of a, the pathway is slow fast.
Yes, typically slow fast.
And it typically is slow fast.
Yes. So here is the P wave, right?
Yeah.
This P wave is now going slowly through the AV node. And then it comes back fast, producing this P wave, and then going down to the V, producing this QRS complex. And it will keep doing it. So we will do this ladder diagram next week also with Atahar together. So thank you. Next one. This one. Here, Hafiz.
অ্যাবলেশনে আপনারা কি মানে স্লোপ ফাস্ট ফাস্ট স্লোপ অ্যাবলেশন কি একই?
Okay. So question is slow, fast, fast, slow. We ablate the slow pathway. The slow pathway, even though the AV node I have made it as a round figure, it is not. It is like a spread out beard, it's like almost beard, like a beard. And you ablate this area. You don't ablate here. So you modify it enough that it stops the tachycardia.
One thing I'd like to make a comment for the attendees who are on call, they get called for the tachycardia. Try to look at the rhythm strip. If you see on the rhythm strip some PAC or PVC, and after that it's starting the tachycardia, you might see the first beat after this extra beat might have prolonged PR interval, or there's change in PR interval from the previous one, normal sinus, and then it starts tachycardia. If you see that, it's always AV nodal reentry tachycardia. So if you're lucky enough to see it, just always look at the rhythm strip, okay? Because you'll see some prolongation of the PR, and it'll start like AV and RT.
Sure.
So, Rohit, two questions.
Yeah.
If it is a typical AV nodal reentry, and there is a little more RP, when you look for accessory pathway?
Oh, the atypical AV node reentry. Oh, let's look at this one, and then we talk about it.
Okay.
Heart rate, I'm giving this low heart rate because I don't know where I found this, 122 beats per minute. Maybe to make it confusing.
Physiologically, reentrant tachycardia more likely to give oscillation than automatic tachycardia, right?
Absolutely.
Yes.
Automatic tachycardia, in the beginning, there will be a little bit of warm up, but after that, it becomes stable. But reentry can have some oscillation, mainly because of the presence of the AV node, which is influenced by the autonomic tone. Good. So maximum, even though it's an interesting distribution, but atrioventricular reentrant tachycardia now. So I don't know how you will answer. Is it just a random press of button or not? But please pay attention to what I'm going to talk about. So this is a tachycardia. And at initial look, one may think there is nothing. But I looked at lead 3. And lead 3, there is a notch in the T wave. And of course, that's where I was dreading Hafiz's presence. But it is consistent. And I thought, in my imagination, this is the P wave, retrograde P wave. And if that is the case, let's look at it. I measured it. From R to P is 180 millisecond, and P to R, 420 millisecond. I'm sorry, it's actually 320. I typed it wrong, 320 millisecond. So it is, RP is more than 80, but RP is shorter than PR. And my initial diagnosis was atrioventricular reentrant tachycardia using an accessory pathway. So let's look at it. Again, I'm going to bring this up. If P wave is not visible, that means it's buried in the QRS, AV node reentry. RP, shorter than PR, if it is very close by to the QRS, within 80, more likely to be AV and RT, and then second diagnosis AV RT. If it is a little outside, then it is most likely AV RT, atrioventricular. And this is what this ECG is about. What happens? Why is it out? Because let's start with the P wave. P wave comes down the AV node, produces the QRS complex. So let's say I produce this QRS complex. And to produce the next P wave, I have to go through the whole ventricle and then come back through the accessory pathway to produce the P wave, and that takes time. And that will produce the P wave a little bit outside, but not too far out. And that's what it is. And is it really this? Yes, this is the patient as EP study. And you can see this, what I imagine. This is the intracardiac atrial electrogram. This is the QRS complex. And this is where I imagine my P wave. And this is where it was. So where is the pathway? So we put catheter. This is the distal coronary sinus. This catheter is here over on the left side. And this shows the earliest P wave. certainly this was the lateral accessory, but you don't have to remember. I just gave it for the curiosity's sake that the pathway was here because it is on the pretty left side. And this patient, this is ECG. You can see the pre-excitation with delta wave.
Ah,
yeah,
nice.
And then we did ablation. This is the pre-excitation. This is the ablation starts within 1 beat, the pre-excitation disappears. So normally, a good ablation, you lose the pre-excitation in less than 5 seconds. If you lose within less than 5 seconds, that means it's not going to come back. If it takes longer than 5 seconds, that means you were far away from the pathway and you did not ablate it. It may come back. So I think I may have, I think that's about it done. I think Wadud wanted the short RP, and I think I read your mind, and we just went through. I hope this was fruitful.
Rafique bhai, apnar last EKG ta, this is one of the most dangerous EKG to miss.
Oh yeah, this one.
No, the one that
No, the
you just showed. The one before that, that you imagination of the P wave. My warning.
Go back. One more.
One more slide, sir. Hey, this one.
This one is one of the most dangerous EKG, because we may say that this is sinus pack, nothing going on. Okay, but clinically, if the patient coming with palpitation, not a normal looking EKG is actually more dangerous. My rule book is look for pre-excitation, look for intervals, look for QT, and look for any noises. That is because why the patient is tachycardia. That's because there is no fever, nothing, and patient coming with palpitation. Something else. Sinus tachycardia, if not explained, makes me nervous.
Yeah. I mean, absolutely. These are the patients that we tend to ignore because the heart rate is 122. If the heart rate is 160, we always pay attention. But we may leave this. These are the kind of patients which develop cardiomyopathy. Sometimes patients don't recognize it, and they remain in this rate for weeks and months, and they develop cardiomyopathy. And a lot of the tachycardia-induced cardiomyopathy that we see will be in the heart rate of around 120, 130 without any symptoms. Thank you. I think we are almost time over.
Sir, it's very nice. Today, and the
So when you did the ablation for the accessory pathway,
yeah,
what is the chance of recurrence?
Well, this is what it is. So if you look at this ablation, see where ablation is on. Within 1 beat, accessory pathway disappeared. That means you are on the accessory pathway. If you are little bit away from the accessory pathway, it will take, people will do ablation and give 5-10 second ablation, and the pathway disappears. That means you actually heated up the pathway from a distance and it disappeared, it will come back. This one, it is extremely unlikely to come back. I mean, recurrence rate of atrial accessory pathway recurrence is, we quote less than 5%. It should be 1 to 2% or less. The mistake people make is that when they try to do ablation, they rush into it. You have to spend time and find the target. And if you spend enough time and make it close enough to the pathway, and you can, if you see the ablation ECG, you can see where I'm pointing, the A and the V are merging with each other. And that's the point. And you see when it ablates, it separates out. And this is the key to identifying the pathway during ablation. Thank you.
Thank you, sir. Thank you. It's amazing. I hope today's class will give some clarification of what do we mean by short RP, long RP, tachycardia, and how do we differentiate between FART and FANRT. We will face difficulty, and as Rafique sir was saying, even he make mistakes and that he can identify long after. So there's nothing wrong in that, because the treatment plan is almost same, and that's the key. But we have to be curious and look at the ECG and try to analyze it as much as possible. And then we can share it with our colleagues or friends or teachers. রিপু, 3 জন পার্টিসিপেন্ট হ্যান্ড রেজ করছে, একটু জিজ্ঞেস করবে কেন?
ওদের তোমাকে একটা কথা বলি, এই ইপিরে এরা কিন্তু ভুল করে।
Yes, sir.
খেয়াল করে দেখো, রফিক ভাই বলবে যে পসিবিলিটিস, and then they will confirm later. We the interventionalists, we jump and we get dinged.
Because Hafiz, you are the Navy SEALs, we are the snipers of the army. We don't talk, we sit there with camouflage on our head for 12 hours, 48 hours. And then if we find the target, we fire one bullet. If no target, we come back home. So who raised the hand? There is any question?
Sir, I have given the permission to unmute, but they have lowered their hands. I suppose the questions have been answered, I suppose.
Okay, all right.
Russell, do you want to put a question in there? Dr. Mustafa Russell? Russell, you did raise hand. Do you want to put a question? Well, anyway, I do think you have answered our queries, sir, quite nicely. We are really grateful. Dr. Nur Alam has shown some very practical examples of problems with arrhythmia and with ischemia. And that's a nice collection. And some has amazed even our teachers. And Rafique sir has clarified some very haunting points that make us swear and sweat, that we cannot clearly identify which one is FERT, which one is FANRT. Now we can say that we have at least 70 to 80% chance of making a correct diagnosis. Not saying this is only SVT, but saying more that it is likely to be this one or that one. Thank you, sir. Thank you, the panelists and review, your team, Kamrul and everyone. Thank you.
Thank you
For
so
last
much.
more than 1.5 years, we are going through these sessions. And this is the 53rd session we have had. And it was really something to go look for. And Chowdhury Ahsan Bhai, Dr. Aziz Bhai, everyone is there. So thank you, everybody.
Thank you. Okay,
Thank
that's
you.
how we have next week. Bye.
Good night, sir.
Assalamu alaikum, sir. Thank you, sir. Good night.
Walaikum salam.